Welcome back, everyone.
I went outside and then I saw many people starting conversations together. I hope you all have a wonderful break. And as we conclude the morning session, I have to say that I'm very excited because also I'm a medical student at Sirirat Hospital and also at Candy, and we're very excited to see how AI has combined it to medical field, and we know that we're having a very, very better platform where we're gonna develop our work and healthcare system in Thailand.
Indeed, I personally found it very insightful and inspiring, the amount of ideas and amount of people and thought that went into each and every project.
Of course. And also, Professor McConnell, we cannot forget to mention him. We're studying about the McConnell sign, and it's very pleasure to saw Professor McConnell in a real person today. So I think let's move on to our next session, Candy. For the next one, we're diving into our next session, which is we will explore the topic about privacy risks and safety of GenAI, implication and recommendations for healthcare industry, offering new insights into how technology continues to revolutionize healthcare.
I'm very excited for this next session.
And I believe that everyone outside is trying to started to come inside the room because I have to say that the next session is very honored because we got Professor Kwok Yan Lam with us. He's a very talented staff from the Singapore. Yes. Okay, so please join me in welcoming Professor Kwok Yan Lam up on the stage. Professor Kwok Yan Lam is the Associate Vice President from Strategy and Partnerships and Professor in the College of Computing and Data Science at the Nanyang Technological University, or NTU, at Singapore. Professor is the renowned cyber security researcher and practitioner. Professor Lam has collaborated intensively with law enforcement agencies, government regulators, healthcare and financial institutions in various aspects of infocom and cybersecurity in the region. He is currently also director of the Strategic Center of Research and Privacy Preserving Technologies and System, SCRIPTS. Everybody, please join me in welcoming Professor Lam Kwok Yan.
I will talk about the topic of privacy risk and safety of generative AI. For the past few years, we've been collaborating with health authorities, pharmaceutical companies, and hospital operators. So we have been looking at the risk due to the introductions or adoptions of analytics and AI. And so of course, we have come across quite a bit of issues from all angles. But so in this talk, we focus mostly on privacy and AI safety. And of course, we all know the AI or generative AI in particular have revolutionized lots of industry, and especially in the case of health sector. We have been working with the health agencies to apply latest technologies in privacy enhancing techniques to do privacy preserving pandemic modeling. That was still during the COVID period. So pandemic modeling was an important area. So we also did the testing with pharmaceutical companies to see how to use the generative AI to assist health professionals to look for the most suitable drugs when they prepare the prescriptions. And we also did testing with hospitals to map or to match the patients with doctors. So these are the various types of testings or proof of concept or collaborations we have in the health sector. So to a large extent, we have seen a lot of improvement in efficiency. But as usual, when we look at new technologies, apart from enjoying the result of the innovation, we also need to balance with the risk. So understanding the risk is important. So we always tell people that when we talk about collaboration, when we look at how to apply AI or generative AI into solving a real-world operational problem, I don't need to tell you what AI can do, because the fact that you ask me for collaboration means you already know what AI can do. It's even more important to identify what AI cannot do, so that we set realistic objective of the system. We identify the risks and shortcomings, and then we address it at the design stage of the system, rather than taking it as a patch later on. So we always aim to balance the opportunity and the risk. And one important thing is to understand not just what the new technology can do, but also what it cannot do. So, and of course, when we look at applying the new technologies, like as I mentioned, we start doing those using large language model to support the operations of pharmaceutical companies. We basically experiment many different ways of using it and look at what are the potential problems. Now, one thing is the uncertainty of the AI models. Now, why we call it uncertainty? Mainly because AI being AI, it makes recommendations or decisions based on probability. So there's never a definite answer. It's based on probability. But in real world, as a healthcare professional, or as long as you use it in any professional domain, you cannot make decisions based on probability. You need strong argument and justification to support your decisions or your recommendation. So that's one thing. That's why people start to talk about explainable AI, not just about using AI to make a recommendation, but to be able to explain the recommendations. And otherwise, we also have seen people just overly trust the systems. And that could be dangerous because there's, again, AI make recommendations based on probability, but there are always outlying cases that the AI cannot capture. So sometimes some way of human intervention is inevitable. Now, we're not saying that AI is hopeless and we still need manual operations. This is not what we mean. But at least in the risk framework, we need to cater for situations that there are data which are in the outlying area that the AI systems cannot handle. So, but what we need is to be clear about how to define or identify those outlying data. So that's why when we run a system, when we operate a system, the first thing is to look at the categorization of the data so that we know for this category of data, which engine can work better for the systems. One simple example, last time we built facial recognition system for border control. And as expected, no single facial recognition engine can solve all the problem. And different engine is optimized for different scenarios. Scenario in the sense that whether it's supervised, that means you take a front picture of the face. In a control environment, that is the lighting. But some AI engines is optimized for different types of lighting. So the first thing is to detect what type of data, what category of data, so then you deploy or you dispatch the facial data to the corresponding engine that can perform the best for this type of data. So at least we don't overtrust the AI engine. We understand the limitation of each of the engines. And of course, we also should not undermine the capability of the AI systems. But after all, what we want to highlight is when we adopt a new technologies, we need to understand the underlying risk so that we can manage it accordingly. But as I said, in the context of these discussions, we focus on data leakage and AI safety. So when it comes to the context of applying AI in healthcare systems, especially when we talk about large language model, if you operate the large language model up in the cloud, for example, you need to upload your questions to the cloud. And the question itself could somehow leak privacy data of the user. And again, as expected, a general purpose model, like what we nowadays call foundational model, is trained with data from all sorts of domains, which means it's not necessarily specialized in a particular area. So we have done a lot of projects in the past to apply the AI model to different application domains, including healthcare, including legal, judiciary, food safety, town planning, cybersecurity. And what we realize is if we just take a model off the shelf and run it, it will work, but the accuracy is somehow not so good. So, which is also expected in the sense that if you ask a person who did a general study of almost all the topic, and then you ask this person the questions, he will not give you a very specialized, specific answer. But if you ask a specialist a questions, the specialist will interpret the questions and explain in the context of that specialization. The same happened to the model training. So if you deploy a foundational model which is trained with all sorts of data, so it is unlikely that if you ask a very professional questions, it will be able to answer very accurately. So based on our experience in the past, in those domains that we have worked on, we usually will need to fine-tune the model with data in that particular domain. So I had this experience last time when we did a collaboration with a judiciary to build an AI system to process court cases. And the first version, we just took an off-the-shelf foundational model. The result was a bit mysterious, obviously incorrect. So we look at it. Then we realized in the court case, there was a evidence, a witness report from a medical witness. So there are medical terms inside. And one of the medical terms to a layman, it means something different, completely different from the context of medical report. So because of this one word, the AI engine will interpret incorrectly for the rest of the report. So this leads us to understand the need to fine-tune model for different specializations in order to have more accurate result. So, but when you do this type of fine-tuning, the training data also could be sensitive. So the protection of the training data also need to be careful. So that means when you operate the AI model or when you train the AI model, we need to be careful of the potential data leakage. So this is something that we have been working on in the past few years also. Not just about designing systems that adopt AI models to solve real operational problems. It's also looking at how to address the risk. And so not just about training or fine-tuning the model and operating the model, but the model output can also potentially contain sensitive data. So these are what we call data disclosure risk of the model. So for the past 1 year, we've been, under the AI safety work, we've been doing joint testing with other countries on this data disclosure risk as well. So basically, in the case of the health sector, just now we talk about things in general, but as you can imagine, the sensitivity or the privacy problem becomes even more serious if we talk about patients' data, health data, or pharmaceutical or prescription data. So especially patient data are most sensitive categories of personal data. And the AI, as I say, it makes recommendations based on probability. And the probability is highest doesn't mean it's factual, doesn't mean it's real. So that's why we have this thing called hallucination. So, and in such case of AI errors, it could lead to harmful results. So so these three things here tell us about privacy risk as well as AI safety risk. And another third area of AI safety problem is if the model is trained with data in one population or in one part of the population, but then you apply the model for use in other population. So you may be causing bias to the target users because you train the model with data in one group of users, and then the model will make decisions, recommendations, and recognitions based on the observation or the learning of the data from this population. But then you apply to another population, maybe even in another countries. We all know people from different ethnic groups may be vulnerable to different types of disease or problem. So will that cause bias if you apply the model to a different population? This is another AI safety problem. That's why we always talk about model testing. When you deploy a model to a place where it is not the place where the training data was collected, then the model testing will be important. So then coming to this privacy part, we talk about training of the data using sensitive material. So one way is to use federated learning. I will not dig into this because there have been lots of discussions about federated learning in the past. The other is machine unlearning. That is, if you train the model with data that is sensitive, and then when you use it, you realize those sensitive data become part of the answer. So you want to remove it. One way is to remove the sensitive data from the training set and then you retrain. But it takes a lot of time and resource. And a simpler way may be to do the unlearning. That is to unlearn those data. So this is one way to address the data leakage. This is another area that we have been working on. And another area is the homomorphic encryption. That is to allow data to be analyzed, processed in encrypted form. So, for example, you work with an AI provider. They train a model with their own data. Then in order to use the model, you need to upload your data to the model operator. Nowadays, we call this AI as a service. But by doing that, you are sending your user data to this third party, which in a lot of countries is not allowed by privacy regulations. So we actually first came across this problem from the financial industry. There's so international financial institutions, they have data from all over the world. They train a very powerful model. Then local banks want to use it, but they cannot because they cannot upload their customer data to the third party. Then the homomorphic encryption will be useful. So to do that, the simple way is to do data minimization, de-identification, access control, and so on. And then homomorphic encryptions. The other is we also look at how to address privacy leakage from the case of the generative AI. Then we may do machine unlearning, we may do guardrails to remove or detect and filter out some of the undesirable data. So this is one example, an overview of how we do this AI as a service using privacy-preserving technologies. And I think this will continue to grow because a lot of organizations, when they use third-party model, even if they have access to the model, they may not have the AI computing environment, which requires lots of GPU. So they usually will use a third-party AI data center. So that will cause the problem. And that's why in the last few years, we've been working on this AI on encrypted data. So we have done this, and we have also deployed this to different organizations. We even use this for pandemic modeling on encrypted data. And so this is the kind of privacy-enhancing data analysis. The data is encrypted, then you perform the analytic on the encrypted data. And the result is also encrypted, so that when you get the result back to the user server, then you decrypt and see the result. So that means the third party who run the analytic algorithms of the model will never see any of the user data. So this is another example that we collaborate with the health authority to do encrypted or the privacy-preserving pandemic modeling on contact tracing data. This was completed and was published as an international report 2 years ago. So it shows when we started this research, people say just as a kind of exploration, don't know whether it can work or not. But we managed to make it work and make it efficient so that it's no longer just a theoretical idea, but we can actually turn this into something that is workable and useful. And the other area, as I mentioned, is the machine unlearning. That is, through the unlearning, you remove harmful or inaccurate data from the large language model so that you can safely deploy it in your environment. Now, this is important because if the model is trained in another country using that data, and they have different culture, whether you talk about religions, diet, habit, and then you deploy it to your country, then the LLM may generate suggestions that is ethically, socially unacceptable in your country or in your society. So that's the reason that machine unlearning is useful for addressing some of this problem. So we put all this into a framework called AI safety framework. So basically, we look at the AI risk into a different level, from the trustworthy AI, which look at AI from a purely technical angle. That is the hardware, the software, the systems, the model all behave as specified. Purely technical definitions. Then we start to move to add in, look at AI as a social technical systems, because after all, the AI is to complete something for the society. So we want the AI to be fair, transparent, explainable, and ethically behaved. So at least it aligns with the norm of the society. Then when it comes to generative AI, we are now having the situation that some organizations, they have gigantic computing resources and data, come up with the foundational model. Then the rest of the world build application on top of the foundational model. And it leads to the situations that if one model have problem, the problem will ripple down the AI supply chain and bring down the entire society. So that's why some countries start to look at GAI as a public safety problem or a national security problem, because it can lead to collective failure of the digital economy. So that's why we call this safe AI. That means we need to test the model so as to address those bigger scale problems. And AI safety is the science of developing techniques to test safe AI models. So these are some of the research that we've been working on in the last 2 years, and we have done it in collaboration with other countries to make sure that the technique that we do, the testing we do can be applicable to a few countries, not just within Singapore. And this is important because of the trust issue of AI systems. Like what we mentioned, it could be subjective, it could be biased, it could leak user data. And so this is one of the areas that we've been working on why we need to test AI models. The trust evaluation of AI systems is very important. And in fact, in the last 2 years, as I mentioned, we've been doing testing and evaluation of AI models. And we have uncovered quite a lot of problems. And we also look at how to mitigate the safety risks of AI systems. And this is extremely important because when we work with our collaborators on real-world deployment, we can address the real-world risks of the AI models, not just some theoretical perspective, but really address the risk. So, for example, we have built AI systems for compliance check for a regional conglomerate. The first version, accuracy was not very good, and with hallucination. So after we apply those AI safety techniques, the accuracy becomes much higher and never have hallucination. So again, it will be too naive to think that one technique, one model can solve all the problem. In our experience, as I said, we did it for judiciary, we did it for food safety, for cybersecurity, for health, almost all the systems we have built. We always identify the shortcoming of each of the technique or model. Then we use the multiple models to work together in a coordinated manner so that one can complement the other. So we look at AI system as a system engineering technique, not just as a single model. So if anyone says that model can solve all the problem, most likely it's a overpromise or overtrust. So to sum up, so basically, as I say, AI being AI makes recommendation based on probability. So in any case, you are bound to have some small percentage of error. And this error can accumulate down the entire AI system, especially when we talk about agentic AI. So testing for those boundaries is important. And if needed, some human in the loop. I'm not saying that human intervention is a must, but when we design the architecture, we need to cater for situation that some human in the loop will be inevitable. One simple example is, if due to company policy or government regulation, certain decisions need to be approved by a human being, cannot be entirely done by AI. Then, in this case, you need to have a user interface to show the interim result to an officer who has the authority to approve the agentic flow to continue. So this is to support the agentic system to comply with real-world regulations and policies. And continuous testing for bias, for safety, and even for abuse will be important. And all this we need to put into the context of governance. So, to summarize, as I said, the human in the loop should be in the architecture. Not necessarily a must, but should be in the architecture. And we need to test, and when we test, if there's any shortcoming, we need to have guardrails, or we need to have other complementary techniques to compensate for the problem. And especially for health sector, explainability is important. Verifying the source or the reason behind the recommendation is important. Because last time we did a proof of concept with a pharmaceutical company. Basically, the scenario is I send a questions, a prompt, describing what symptom I have. So I expect the system to tell me what is the most suitable drug. I did this test on a public systems, those ChatGPT. You come back and say, for this type of question, you go to see a doctor. Don't ask me. but of course, when we build it for a real-world pharmaceutical company, we cannot have this type of answer. But we also need to have an answer that is explainable and can cite the source. So by using a combination of technique, we can build a system that, based on the description, we explain you can use this type of medicine, and based on this manual or specification or the drug specification. And based on this drug specification, when you take this, you may have this side effect. So if you have this problem, then you should not take this, you should take another one. So that is how we build a system that can address the safety. So that's why I have been emphasizing the importance of AI safety in health sector. So I think I have used up my time. So thank you very much. If you have any further questions, I will still be around. I'll be happy to have further discussion with you. Thank you.
Thank you, Professor Kwok Yan Lam, for that thought-provoking session.
Now it's time to begin our first panel discussion of the day. The first panel will be about accelerating mass adoption of AI for public health. This session will bring together outstanding leaders and experts from Thailand, the United States, and Singapore to share their invaluable insights on innovation, healthcare, and strategic collaborations for the future. Please join me in welcoming our distinguished panelists, starting with Professor Dr. Yongyut Siriwattana Akson, Director of Siraj Hospital, Thailand. Professor Dr. Michael V. McConnell from the U.S., Clinical Professor of Cardiovascular Medicine at Stanford University and Chief Health Officer at Toku Health. Dr. Xiong Wei Yang, Vice Provost, Strategic Research Partnerships of Singapore Management University.
Dr. Kitphaka Bunfeung, Executive Director of National Innovation Agency, Ms. Nadia Suthi Kunpanit as our moderator. Now I would like to hand the stage over to Ms. Nadia to begin the discussion.
Please welcome them on stage.
Thank you so much, and good morning, everyone. I think we are in it for a very exciting panel. So I have here with me the distinguished panelists. The topic for today is very relevant and also very important. We will cover areas of real-world examples where AI can really make a difference and also improve, public health, which is facing a huge stress from the quality of care that we need to consider, the speed of services that we need to adhere to, and also the increasing medical inflation, as well as the lack of doctors and nurses in the system. So without further ado, I would like to hand over to our distinguished panel to introduce themselves briefly, and then we'll get into the questions.
Hi, I'm Dr. Yongyut Siriwattana. At this moment, I'm a director of Siraj Hospital. Thank you. Actually, I'm surgeon by training.
I'm Mike McConnell. I'm a preventive cardiologist, clinical professor at Stanford, and chief health officer for Toku.
My name is Wei Yang. I'm currently the Vice Provost for Strategic Research Partnerships at the Singapore Management University and also a Senior Advisor for Health Economics at the Ministry of Health. But prior to this, I was also the Deputy Secretary for Technology at the Ministry of Health in Singapore. Yeah, thanks very much.
I'm Kitphaka Bunfeung, Executive Director of National Innovation Agency, Thailand.
Thank you. As the intro suggested, I think there is a lot of things that we need to cover and also need to understand. So maybe I'll just start off to kind of, get into the topic a little bit and start with this question on where do you think AI can really make impact? And also in terms of public health that we mentioned before is really facing a lot of pressures. which area do you believe AI can make the most transformative, impact, and also the reason why? I want to maybe start off with Dr. Kritpaga, and then I'll hand over to Professor Michael.
Yes, thank you very much, Nadia. And I would like to apologize all the listener because I have to finish my presentation soon and I have to go to the airport. And I think my will cover everything that successful and also important issue that you may learn. Can you give me my slide, please? Yep. Actually, as the National Innovation Agency, we are the granting agency. We are support so many SME and startup, including the social enterprise in the area of innovation. It means that when we're talking about accelerating the mass adoption of the public health, I think it's really important because when you're talking about the public health, it means that they have a lot of data that related to. And however, in Thailand, in the data security, they have so many issues about the data sharing and everything. We try to do so many projects and also support our SME and startup to work on the data, how to utilize the data, how they can manage the security and make the trust between when they have to exchange. You may see that actually we are focused 5 sectors. You will see that one of the sectors that is very important is health and medicine. Because of this one, we think that AI, robotic and immersive technology is very important for the health. It can be for the advanced, for the robotic, and also it can be for the data and can be quantum, it can be the blockchain when they have to control and send the data, including all kinds of the PDPA when they related to the information. We work closely. I would like to show this picture because when we want to make Thailand as the medical innovation hub, the most important thing that the data, they have to be flow among the region. We run very successfully in the Yoti Medical Innovation District, that one in the area of the Nanyang University, Lam they have also the cancer hospital, Pamangkut hospital. That one, they are the list of area of health and public service. We work this one for almost 6 years. The first thing that we do, we sharing the data. For example, we share about the data of the doctor, availability of the bed, and also all kinds of treatment that they can be shared. After we run this one successful, sharing the data and information for everything, we move this one to the Sondok in the Chiang Mai to work the same model. And UT Medical Innovation, besides, we work closely with the linkage between the public hospital, but we also work with the private also. For example, BDMS Group and also the many government to join this one. And this area of the UT Medical Innovation that you see, we get the extra BOI from the BOI also for support incentive for investment related to research, innovation, and commercialization. And also, this time we work closely with the Sirirat to make like the Sirirat Medical Innovation District will be one part of the health system in Thailand. And also in the northeastern part, we work with the Khon Kaen University. And they will have the Khon Kaen Medical Innovation. It means that the important thing that we want to encourage them to share all the information, share the technology, including the treatment and everything. That one we can make Thailand as a medical innovation hub. And it means that in the future, if you are the startup SME, you have the product that fit in and government can use it. It will be the test bed and the sandbox that can you launch your product in here. And if the the public hospital uses and the doctor agree with that, in the future you can springboard you to the private company, private hospital, including in the global market in that one. When we also have the support in SEPTRA, that one they use AI technology for monitoring in the health, and we work closely with BDMS, and also DigiPro will be the 3D, and they have a lot of data in dentists also. And they also, GenForces will be AI recommendation for the health and everything, and UCA, that one, if you have the mental issue, you should use UGA, but right now I'm still okay. And this one will be our accelerator program on the health, will be the SpaceX. When we work with the regional and also the area, I will have the SpaceX to cut across and bring technology to meet with the user. And this one, we will work closely with the government and the private sector to run the SpaceX program this year. And also welcome all the hospital, including Sirilat and everything, to work closely. And this one will be the focus on the partner, and also oversee will be the how they can make the product that can be available and acceleration program. Thank you so much. And I'm apologize that I have to go because I have important mission to go to Saudi Arabia to have bring our startup to be there and signing the MOU with the most important thing. And I think this one will good for our ecosystem, and health will be one of the issue is the Middle East would like to work with Thailand. And I think I will come back with the good news. Thank you very much. And I apologize for everything. Thank you.
Thank you so much, Ka. ขอบคุณค่ะ Thank you so much, Dr. Gripaka. Actually, Dr. Gripaka covered the second question as well, which is collaboration. And to kind of sum up what she just said, I think the National Innovation Agency, or NIA, is a great example of bridging between public-private collaboration. But I think what we also want to understand a bit more is where AI can really, make those transformative impact. I'm looking at you now, Professor Michael. I think you are in the field as well as, been from both academia as well as startups, as well as leading some of the organization within the health sector, for example, working with Google. It would be really interesting to hear from that aspect from you.
So what's going to have the biggest, or how is AI going to have the biggest impact? That's a real easy question, right?
Mm-hmm. Yep.
So there are many answers there. I can give some practical answers. If you see what's happening, say today in Stanford Hospital with generative AI, I think the big areas that have been deployed already are a lot around helping the efficiency. My bigger goal is to improve quality of care, but when you have a system that takes a lot of work and it has a lot of administrative steps that then limits the amount of time that doctors can spend with patients and contributes to physician and other clinician burnout. I think things that do make the day-to-day work of clinicians faster, easier, and feel less, tiring of filling out forms or typing a lot. So that is happening, and then we actually, at Stanford, they've launched a chat EHR system, so you can actually ask, it just works within our EHR, but you can ask it to summarize everything that's happened with the patient since their last appointment, right? Because if you try to search through the entire EHR to find every single note and lab test since the last visit, that can be very hard. So there are some very practical things that are happening today that can make workflow go more quickly. I think the other big area of impact, and I think you saw in some of the examples and some of the things that I showed, the FDA has cleared hundreds of software as medical devices that use AI, and the vast majority are in radiology and cardiology. So the ability to leverage AI to analyze images. So I think we saw an example for mammography and improving breast cancer detection. What most AI programs have shown is that the AI may not be better than all human beings, but AI is typically trained against the most expert clinicians, and so it means that everyone can get expert level analysis, and we obviously don't have enough experts in every single field around the world to give that. So the ability to up-level, to provide many more people with expert level analysis of their images, I think that's already happening, and that will only continue to grow. the part that I'm particularly excited about, and we've started to talk a little bit about, the data that comes together in health systems. Can we have a more proactive monitoring system? As a prevention person, many underlying diseases, honestly, and your risk factors, the data is already there in your health record, just nobody's connecting the dots and letting you know and sort of giving you the recommended next steps. So the idea of, similar to how, our cars have all these systems and is monitoring data, and it'll have a check engine light that if it sees something isn't quite right, and then your mechanic can plug in and see which system is going wrong. We're now in a world where we should be able to have more of this proactive monitoring of our data to let us know, oh, you just crossed into prediabetes, or your risk score for a heart attack is now above the level where we would recommend, getting your cholesterol lower. So, leveraging AI to keep track of our health data and really inform and be proactive for early detection and awareness.
I think you touch upon a very two distinct points in regards to the data themselves, right? One is data is being used to improve the efficiency for physicians and care providers. On the other side, you also touch on data being used for the end users or the, us mere mortals, right? The consumers and the patients themselves to elevate our understanding. But there's a debate on that point, and I'm going off script here because there's a conversation that should patient see those data, and will they have enough knowledge to act on it, and how do they appropriately act on it?
It's a great question. But with our electronic health record system, in many, particularly my return patients, I try to work on my note and update my note and update the action plan and all their labs, as I'm talking to the patient, which, is sort of one of the realities of modern healthcare. When our EHR system goes down, you spend the whole time just talking to them, but whenever it's up and running, we're sort of working with that. But one of the things that always still amazes me is when my visit's done, and hopefully I've finished my whole note, and I click done, half the time my patient's phone dings because they literally get my note the second I hit I'm done, which I think is a very transformative world we live in.
Wow.
So they get every note, that I generate, and it literally happens within a second of me clicking done. So I'm a big fan of empowering patients with their data. It can be challenging to try to explain a lot of the data, but I think the proactive monitoring could happen both
Ways.
A patient could have a system, that could live on their phone that could monitor their health data. But I think and we talked earlier about how do you appropriately use more national health data, to help track individual health status and let them know when there's an issue, or do you let their doctor know? People usually don't always want their government to know. So, but we both had experience with the exposure notification system software and how governments tried to find that balance between public health and individual health and privacy. And so that's where the challenge is if you want to use more national health data systems for monitoring your status. But I think those are, problems that if we have the opportunity to do that, I think we're all excited to figure out the best way, and people could potentially opt in or opt out accordingly.
I think that's a great point. It's the choice of the data owner, which is all of us, as well as a two-way communication between the physician as well as the patients themselves. So it's not about we have to interpret our own data, but how we can work closer with our physicians to help us navigate our health journey. Coming to that point, I also want to kind of pass on to Wei Yang in regards to that note about collaboration and the utilization of the national health data, and also how can that be powerful in transforming, the healthcare system.
I think one of the things that the public health system has, which many of the private sector craves for, is the records that we are able to have over a large population. Now, of course, part of the issue I think that we have been confronted with is that the incentives have not always been aligned in terms of the outcomes that we are looking for. I think in the new age where we are thinking about AI and how AI gets more accurate the more data it can feed off, in some sense, right? And yet, on the other side, we are worrying about sustainability of healthcare at the public health level for everyone. If we then combine the two and think about a system or a world where, in return for the contribution of your health data, that allows for companies to sharpen and improve the product offerings that they have, you are then given health advice or health insights, which help you to maybe maintain your health, prevent disease, maybe not quite at the level of a really professional doctor yet, but at a level that allows you to maybe stave off the need to see a doctor. Whether that becomes a system that actually can result in a much more sustainable health system that is a form of a public partnership. So I feel that if we start thinking in those lenses, start thinking a much more preventive health approach, start thinking more in terms of actually where is the value, both from the perspective of the patient as well as from the perspective of the companies. And here I would say the companies are not just diagnostic companies, they are not just therapeutic companies, they are banks, they are insurance companies, they are the actual coffers of the public health system, going all the way to the Ministry of Finance, thinking of actually who's going to pay for the maintenance of health of a population so that our economy continues to be productive, right? But the problem, of course, is then who's going to blink first? Who's going to start the first payment? How do we arrange the structures, the data, and the benefits to flow in such a way that the incentives are compatible, the data architecture gives the assurance of privacy and confidentiality for the people contributing their data, but at the same time, the big data insights that ultimately make us much more effective, I think can be applied. The second perspective that I wanted to also introduce is this idea that in the end, if we start thinking about whether AI is as good as a doctor, I think we are barking up the wrong tree. Like I said, AI that's based on some of the most expert insights will likely be better than a junior doctor, but will never probably be able to be better than a senior expert doctor. But within that is also how do we structure ourselves such that in areas where there's no doctor, the AI doctor is better than no doctor. Where there are doctors, can we actually make sure that the senior doctor is contributing their insights into the AI system? The junior doctors are learning from the AI system, but not leaving their brain behind at home, but still using their brain in terms of seeing each patient, being advised by the AI, but also in that process, learning what the AI sometimes misses, learning what the AI sees that he forgets to see sometimes, and in that process, improving their own craft. I think that way of thinking about how such a coexistence of the two human and AI systems is really where we need to be thinking much harder about. The interface between the economic and the health cost aspects of a public way of thinking about healthcare, I think is the other sort of like a nexus that I think we need to think about. Yeah.
I really love that point because I'm from a health insurance and life insurance company, and we were just talking in the panel room, prep room, that in Singapore, all claims from all companies goes to Ministry of Health for an analysis, right? And that gives the power back to, I think one of the key words that we use a lot in insurance is appropriation. What is appropriate and what works in terms of delivering care, as well against the cost that the country or the patients themselves and the customer themselves has to pay in terms of premium. So having that in the system and having that as an infrastructure, I think it will fuel the development and also cross collaboration between not just healthcare, but also financial sector, as well as government to look forward and look ahead in the future. I think that's a really, really important point. Thank you. So I'll bring it back to Dr. Yongyut a little bit. And we talked a lot about data. We talk a lot about up-leveling, right? AI is better than no doctor, right? It doesn't replace doctor. It doesn't replace expert and physicians. But it's actually better. And also, it can also be useful for physicians to enhance some of the speed as well as consultation. Is that true, and what's your view on that point?
Okay, it's quite difficult to answer in one word because we are in the situation of the, AI good or not. But in my point of view as a physician and a surgeon, I think AI, it has a pro and cons. So it's like in the past, I'm in the era that still using the textbook in the, like a paper and read it and write it down, something like that. But nowadays, the world changed. Like AI, I think that at the end, AI cannot totally replace the, tactile, relationship between doctor and patient, because AI know any, we cannot write down the algorithm in the individual for each patient, because as a surgeon, when we decide to how to operate, how to treat, how to cope with this cancer, it depends on individual. We cannot write down go to that way, this way. So AI, in terms of the role nowadays, they like the assistant, the good assistant in both ways. Assist a physician is good because we can reduce time and just ask AI, but don't believe all. and also resist to the patient and their families. That is a really tough for the physician because nowadays they will come to the clinic with a ton of the questions and they jumped not to the, for the standard treatment or guideline, but they jump to the ultimate goal like a targeted therapies, immunotherapy or something like that. So I think the role of the diagnosis and therapy, we have to carefully use it. It's much more better and better nowadays. So I would like to just show the audience about some example that AI could help in terms of diagnosis. We heard from in this early morning that in terms of diagnosis from the X-ray film, we use since 2020 for the breast nodule or breast cancer. We do the mammogram using the AI and also the brain lesion. We found that sometimes the AI is some point is better than physician because if the radiologist they see let's say 10 or 20 of the film in the dark room, just only the the light from the from the and they can miss just a little bit of the small nodule. So the X-ray film, I think, sometimes it can detect some missed nodule. But at the end, at the CLAT, we still need the radiologist to make the conclusion, the final conclusion. We don't allow AI to write down the report unless any radiologist to sign out and click the done or something like that. So you see that we can, if you look at the left-hand side, sometimes we cannot see any nodule, but the AI can alert that, okay, in some region, there's something wrong. So now we use the AI to spreading to all the area in Thailand. In Thailand, you might know that we're still facing with the problem of tuberculosis. And also not just the simple tuberculosis in the past 10 or 20 years. Now it is the strain that multi-drug resistant, especially when it occurs in the immunocompromised host, such as the HIV or the one who received the immunosuppressant. So we have the new patient about 120,000 per year, and the cause of death is up to 10% of that number. So we use this AI to detect the TB, and we found that when we use this AI on the truck, we can go to the high risk and endemic region, such as in the very crowded and not so well protection of each member. So we spreading and combine with the company named the Percepta, and now we can install more than 90 medical centers to try to early detection and treat the lung nodule and also the TB as well. And also we go to the south, to the north, and you see the increasing of the number that we can detect of the patient, and we try to get rid of, otherwise it's going to be still spreading to other patients. With the chest X-ray film, it's not just only the lung nodule or the tuberculosis. There are about more than 20 findings that you can detect on the chest X-ray film, and luckily the AI is sometimes better than the radiologist who or any the GP who just graduate and go to work in the other part of the hospital in Thailand, that is just use the AI to help and assist the physician. The other thing is the brain lesion that the AI can detect. This is a hemorrhage, or infarction, and also the mammogram. The other one that I wanted to touch is as a diabetic retinopathy. This is one of the silent complications that occur in the diabetic patient nowadays, because if we cannot early detect that when they have the diabetes, what happened to their retinas. So the pain point is that you see that if we have to detect the DR, the diabetic retinopathy, in every patient, we cannot do the dilate the pupil, and the patient will have the blur vision for about 4 to 6 hours. And then we use a lot of staff, including the physician. So we use AI to differentiate between anyone who quite normal of their retinas. So we can separate this group without referring to the ophthalmologist and the one that we need to refer. So at the end, we can reduce down about 30% of the patient that really need to be seen by the ophthalmologist. So this is the one that we think that AI could help, but still ophthalmologist will still there. The nurse have to still there. So we decrease the waiting time. So per day we can increase the number of patients that come to do the screening of the some retina. So at SixMIThack, we have the principle that if we can't do something, we have to sharing or offering to the other part of the hospital. So this example of the X-ray and the fundus examination, we try to give to all the hospital in Thailand to help in the widespread of the Thai people, and that for this moment. Thank you.
It's amazing. I really like it. And maybe just a follow-up question a little bit. So these AI application has already been widely used and in a real setting, right?
Yeah.
It's no longer lab use,
Yeah.
right? Correct?
Especially for the chest X-ray now, it's like go to the universal health coverage
Fantastic.
already.
Right. What you just showed actually has a real world impact and also implications in terms of prevention and early detection, right? It helps democratize some of these tests that may in the past be centralized in large hospitals as well as big medical setups. But now, for example, the case of TB is being deployed all over Thailand. Do you get the data back into the central system in order to act upon? Is it real time or near real time?
Yeah, we try to gathering all the data, and Silat is one of the hospital that become the one of the TB group Thailand to gathering all the drug resistant strain and also in the immunocompromised host.
Yeah, and this will, I have a follow-up question on this because it has an implication on cost and prevention and early detection have direct implication on cost. So maybe I'm looking at you, Professor Michael, again. Can you maybe share a little bit in terms of the impact, the positive impact, or any impact in relations to the proven quality as well as proven positive impact from the prevention itself, and how does it affect in terms of the cost savings that we can see?
So yeah, I'd love to follow up on the diabetic retinopathy example, right? And it was actually after Google developed the initial software, one of the first countries they worked with was with Thailand, and have done multiple publications showing how it matches expert doctors and has been very effective as part of the national screening program. And one of my colleagues at Stanford, which uses a similar system, has published that importantly, sort of the biggest challenge, across all health systems is every diabetic is supposed to get this done every year, and yet even in most places only about half do. And it's because, one of the phrases you learn in tech is this idea of friction, right? Every time there's another step somebody has to do the right thing, you lose another 10 or 20%. And so every friction step, you tell 100 people to do it, and then in the end only 10 do, because it turned out that there were many friction steps along the way. So the idea that these systems are often put right in the clinics where they're getting seen anyway, either community clinics or at Stanford in the primary care clinic. That reduction in friction not only means more people are getting screened, but the other study that Stanford did was because they got the information that you should see ophthalmology, you got that information at the same time you got the scan because it showed retinopathy, and you may need treatment to prevent blindness. There was a much higher rate of people actually making an appointment and getting the next step in care. So I think there's a lot about these systems that can have important impact, not just on the accuracy of the diagnosis, but the likelihood that someone will get the scan and will follow through on the findings of the scan. That's sometimes more important than just getting the scan in the first place. Yes. So I think we are seeing, an impact of AI in multiple steps or multiple phases of the care pathway that's positive. So,
thank you. And maybe to you, Wei Yang, on that same point.
Yeah, so I think the key thing is, and I really like there was a phrase that you used where it says that it's helping the hardworking doctors, do more. I think we have to be very clear that we are not trying to say the doctors are doing too much. And the question is, how can the AI help the doctors do more and actually reach more people? As doctors, the concept of triage is something that sticks heavy in every doctor's mind. When you have time, you have 3 patients in front of you, all of them are dying, which one do you treat? Right? Okay, maybe our patients are not quite dying, but the reality is that because we do not have enough doctors, especially in the more developing countries where the resources are actually limited, the question is how are we going to reach out to the entire population to ensure that, first of all, we help them to maintain their health. Second, they don't end up being acute patients coming into our public health system to the extent that we can't cope, especially if there's an aging population. But it does require us to rethink, actually, when you talk about cost effectiveness, what exactly do we mean? Right? Is it cost effectiveness for a specific procedure, or is it cost effectiveness at a per capita level? Right? And I think defining the right metrics is part of winning the debate at some point in time. Right? If I think of the cost effectiveness at a population level, all of a sudden it becomes very clear why we must be thinking much harder about AI and data systems that allow us to apply AI well. And even this idea, I know for most physicians, they say, let the doctor still sign off. And I was just having a conversation with one of the physicians from Singapore. Every time you make the doctor must sign off, it's a burden on the doctor, a psychological burden. They say, do I trust the AI? Do I now have to now scrutinize before I sign off? Or do I just click yes? And all this actually then adds unnecessary potentially to the burden of a doctor if we are not careful about how we do this. One of the things I always like to tell the doctors is that AI is not artificial intelligence. It's augmented intelligence. It is going to make you smarter, faster, and allow you to do more things. But each doctor is now able to scale their expertise across more patients to benefit more people in a shorter amount of time and still go home and actually have some time for their kids, and their loved ones. All right. AI is also not about, replacing doctors. It's actually going to make doctors immortal, right? Because all the insights that you develop as a doctor as you see patients and have an AI assistant working alongside you, you will actually put into the AI because you'll correct the AI each time the AI tells you something that you don't quite agree with. And of course, we allow the senior doctors to do that, right? The junior doctors learn from the AI and question the AI over time, but as they get more and more senior, they begin to say, no, I've seen this case, I've seen that case, the AI hasn't quite raised it, and I'm going to flag it. But each time that flagging occurs, the system actually helps the next generation of doctors to actually develop faster, better, and actually help to say, okay, but these are the 20 other cases that didn't quite correspond to it. Do you want to just take a look through to see if this particular patient in our field might actually correspond to those cases? I think it's a matter of how we use it. Because as we move towards the idea of much more preventive health, okay, you must understand that any preventive health system is not going to be cost effective if you're going to screen the entire population, let's say every 6 months. The only way a preventive health system is going to work is if we are able to stratify the population and scan at the right frequency to detect with the right percentage involved in those type of frequencies based on a certain understanding of what that population statistics actually looks like. And without that data, without the AI helping us to do that, we are actually blind, right? So I feel that as we move towards a preventive health approach, cost effectiveness is about having enough data to know when and how you intervene. And actually that, to me, is the crux. That is the way we achieve sustainable healthcare. It's not about worrying about how we're going to pay for it, how we're going to get the insurance to pay for it, because if we use the current system of healthcare to try to deliver healthcare for an aging population, we are going to be screwed. Okay, we need to find a new way of thinking about health and health provision. We need to think about how is a doctor involved. I send a truck out, do I send it with a nurse or do I send it with a doctor? Do I send it with a nurse and then I know that I now have telehealth to zoom in the doctor when I need to zoom in the doctor, right? Do I say that every doctor must sign off on the AI, or do I say that I will allow for an audit system on the AI to be then presided by a human doctor? You pick a few and then you just look at it as if this is a patient in front of you, and then we see how often the AI makes a mistake, right? Leave the doctor maybe out of some of these responsibilities, but the responsibility of the system as a whole is still there because the doctors are still making sure that the AI is actually doing its job. Right? So I feel that some of these things fundamentally changing how we think about how the whole system will work is the only way for us to get the most value out of a system like this.
I was just going to add a couple of things. Your point about primarily having the senior doctors contribute to further training of the AI systems, that sort of That's what Google learned with the first diabetic retinopathy. They had to have ophthalmologists, label all the images as this is retinopathy, this is not retinopathy. But one of the things they noticed was they had a lot of variation. There was a lot of disagreement among the ophthalmologists. And so if you have sort of noisy input to the training data, then you don't get an ideal. So they further tuned their algorithm by just getting retinal specialists whose career was very much focused on retinopathy. And that's where then they could just, your point, you could have it work at the level of a senior doctor, not just sort of the general doctor. So that was super important. I think your other point around how do we focus resources and screening and sort of intervention on the people who most need it, particularly when you have limited resources, both financially and in the workforce. It's this interesting trade-off in cardiology. We've always had a fairly, well, one of the things I put in my book, when I learned as a fellow, you would do cardiovascular risk by just adding up on your fingers. If you were over a certain age and you had diabetes or hypertension, if you had 3 out of the 5 things, it was very easy to do. But then we got more sophisticated, and so we have all these risk scores, and you can't do them in your head. I pull out my phone, and I'll put the numbers into the app on my phone that does the calculation, and there are some features in the health record. But ironically, the more complicated and personalized we've made the risk scoring, the less likely it happens, because there's an extra friction step and complexity. And so this is where the technology is really quite behind. I totally agree. We have these personalized risk scoring systems, and that AI is only making those even more precise. But we really need to make it easy to use so that it's not just a good publication by the American Heart Association, but doctors on the ground are using it. So a big fan of how do we put the resources to the highest risk folks, but we need better integration of those technologies into our daily workflow.
I, again, love that. I can't think of how many times I said I love this and love that in this panel. But what you just said got me thinking. I think we talked a little bit about that before the panel, that if we have enough ongoing data, finessing the analytics as well as the AI algorithm itself, could we one day shift from a standard health checkup that hospitals or the standard guidelines said to us each year, okay, you go for a certain age, you have to do a stress test, which means nothing. But can we really achieve a more personalized and a timely checkup for that prevention to happen?
It's quite like a thin line between the personalized and over checkup. I think Professor Cornell, you said that if you have the scoring to summarize the risk, if that one on the hands of the people or patients, they are so scared and they gonna come to the hospital every day with that, oh, I'm gonna die, I'm gonna to be the, cardiac patients or something like that. So I'm concerned about this. In one day, it's gonna be your insurance gonna facing with the, too much or over
Testing.
And
You could just have them see your avatar.
And not only the screening, but also the treatment.
Yeah.
Yep, they're gonna jump to the, Yep.
But I feel like the hypochondriacs will always be hypochondriacs. You can't really stop them from wanting to come and see a doctor for all sorts of reasons. What I worry about is the people who think they're perfectly fine, but actually they are not, right? So I think you need to strike a balance between the two indeed. And so for some, it's actually convincing them that they need to maybe do a few more checks and maybe to do some preventive intervention, which is hopefully easy enough for them to actually go ahead with. On the other side, the same device could be used to say, actually, you're perfectly fine. You look at the score tells you that there is no reason why you should be in the hospital, please go off. So I think it can be a double-edged sword, but I feel maybe how we use it and maybe some way of doing it in some conjunction with the insurance people who otherwise will end up paying for their intervention, who say, okay, if it's like this, if you keep showing up, I'm going to up your insurance premium. Some of these things may be part of how we manage. So it is a valid concern, but again, I feel like it goes back to how do we design the system in such a way that everyone is in a way contributing their part to making the system sustainable. Yeah.
And especially in the genomic screening, now the trend is increasing, you might know.
Right. So I think the conversation just now, we have to balance between clinical guidelines and commercial guidelines, right? And they don't see eye to eye. So I think we have to really have a long discussion and a separate panel on that point. But I really appreciate the contradicting view, which really helps fuel the discussion and also get us thinking about what is really appropriate. Yeah. And finally, I think I want to leave some time for questions from the audience, but one last question from me is on the barriers of adopting AI, right? We think when we talk about AI, top of mind, we may think about technology and the lack of technology, the lack of data. But is it true that these, technology or data is the hindrance, or is it something else? And I really want to hear from all of you.
Maybe I'll start. I think one of the bigger issues we probably need to deal with is how do we convince our healthcare colleagues, healthcare professional colleagues, that this is a better, a way to help them do their work better, and maybe to do the things that matter more from their perspective as well. So for example, in Singapore, we do have already being rolled out, and also of course, even as you roll out, we continue to test to make sure it's fine, sort of like a chat system that actually just records the chat between the patient and the doctor, and then does a summary for you at the end of that chat, and the doctor reads through it one time. I mean, okay, so this must be compared against the current sort of like imposition on the doctor that at the end of the day, they have to write down these notes and key into the EMR system. So if you weren't doing it, then obviously you will say, this is still a waste of my time because I got to read through it and then vet it. But the flip side is that currently they're expected to write that in, even if not at the end of the session, at the end of the day. And of course, that means that they go home at 9 o'clock instead of 7, right? So because there is that imposition already in place, when we then say, okay, the AI can help you to record the conversation, of course, it's not a verbatim that matters, it's a summary that then they actually read through and vet through and then sign off to say, okay, indeed, these are the doctor notes for this particular session. I think they then say, okay, this is actually helping me, and I'm much more willing to adopt it. So making sure the clinicians understand how it helps them to do a better job, helps them to actually cover patients that they otherwise won't be covering. I think it's important. But I think one of the things that I always keep in mind is that doctors are trained to see the patient in front of them and do the best for that patient in front of them. So which is why even the triage concept is something that already expands the doctor's mind. Say, okay, if I have only 1 day or 3 hours, what do I do? Because otherwise they'll just focus on the patient in front of them. But the reality is still that we need to then help doctors to see that it's not about just the patient in front of you, but also all the other patients that you're not able to see, in order for them to realize that the AI is there to help them. And then of course the question is then, how do we convince them that AI actually is good enough for certain users? And this whole idea of you screen 70%, you only see 30% of the patients is actually the one way where it actually really does help. But what then requires is that the department must agree that the process patient workflow has changed, right? And of course, with it, there'll be some risks, but there'll be some audit sort of like systems that are put in place, which as a whole still achieves the original objective of what the doctor was trying to do. So I feel that this conversation of trying to get doctors on site agreeing and understanding why the AI systems are going to be helpful, to me is one of the most important things we need to be able to address. Yeah.
Sure, I think that's a great example where the most rapid embracement has been the things that help speed up your day. So being able to summarize notes, and we have those things like all the insurance authorizations and all these other things that can be very time consuming for the staff. So
I'm sorry.
there's a lot going on there around sort of the efficiency. I think the classic buzzwords in sort of tech when you're trying to bring AI into healthcare is, how much does it involve changing the workflow, right? The biggest pushback is if it takes me longer to do something else to put in this new AI tool, then there's, it's much harder to get adoption. So often that's sort of the first thing. How do you design it? May generate higher quality outcomes down the road, but if it takes more time and complicates the workflow, it sometimes just doesn't get implemented. So I think that's probably the other. And then there is that inherent barrier that AI can be viewed as threatening for the physician, right, or the clinician in general, right? We're often, we go to school for a long time, we're taught that you're supposed to be the smartest person in the room to answer these complicated health questions, and now you have AI saying maybe it's smarter than you, and which is the patient going to trust, you or the AI? And so there's a lot of challenge to think about how to be augmented or assisted by AI without feeling threatened by AI. And I think we don't know the ultimate answer of where this will all go. I always think of the examples, self-driving cars is the other big one that people use, but I also think about, chess and AI, and, the best chess players they've become better because of AI. They learn new moves, they learn things that no humans had thought of, and they can bring that into their game. So yeah, I think there are pros and cons as we go forward, and I think try to have an open mind, and at the end of the day, the big goal is not your own ego, but can you improve the care of patients?
Amazing.
Could I just jump in there? Because something that triggered me as you say that, right? Because how we think of the AI as part of a capability development system, I think is going to be important as well. Because the reason why the AlphaGo was able to beat Lisedo and so on is because they had a dueling AI. The AI was fighting each other over time, right? So, but can I have a dueling AI for our doctors, right, to actually help them to improve their craft over time? Now, but of course, that requires the doctor to accept and say that I actually want to keep improving my craft. And I know that for the best doctors, the most expert doctors we have in our system, they are actually constantly attending conferences and so on because they are wanting to learn the latest, what people have been doing, so that they themselves try it out when they see a patient that may need it in front of them. So how do we help people to see that as part of a professional development pathway even, I think will be quite important. But I think even as I then thought about that, one of the things that then struck me, and I think in Thailand you might have a similar problem. In Singapore, we have the private doctors in the private hospitals who earn a lot of money from treating patients who are very able to pay and will feel threatened by a system like this. But in the public health system where the doctors are constantly not having enough sleep, having too many patients, this thing is actually a godsend. But yet the most senior doctors in our system are the ones in the private health system. So we have to think through how to get them on our side. Otherwise, they'll keep saying that AI is lousy, and then we'll have a problem. So anyway, I just wanted to flag that out. I know it's an inconvenient thing to put out there, but I think that that's something that may be something we need to address. But at the systemic level, it is important to make sure that incentives are somehow aligned as we try to roll out these systems. And here, that's why it's useful this topic was about public health. Yeah. Because in public health, we just need to make sure that we are actually serving the unserved as much as we can. Yeah.
And I think we hear quite a bit in terms of barriers that the adoption is facing, and you are the ones who are putting in place some of these adoption. How did you overcome some of them?
Oh, still cannot. I think because our panel is like our age. If we have a panel of the 20 or 30, you're gonna get a different angle. So in terms of AI in terms of the education and academic, that is the other one that I'm very concerned. Now you see that a medical student, when they write down the medical record or everything, or even the publications, AI just 1 minute and finish. So we are facing with the data that gonna create by AI. So that is a very sensitive, and we have to concern about that. So can I add up a few more slides? Could you bring up my slide, please? And thank you for my colleague who is a fancy with the AI in terms of the treatment in the another angle using the robot. We know that when we use the robot to do the surgeries nowadays is increasing by the many companies, and you see in the past, like you said, the self-driving car, how come? But nowadays it's already established, and this one as well. We use the arm of the robot. But interestingly, I'm gonna finish with this slide. I love this, and I show you that the increasing of the using the robot assist a surgeon to do the surgery is increasing and more than 10 or 20 times. But this slides as I'm a surgeon in the old fashion. On the left hand side, we still use the my hands, my heart, my eyes, and we are in the middle in the red square that we use robot as an assistant nowadays. But you see with the AI, now in the future we might be the patient who lie on the bed and the robot gonna do the surgery by itself. Self-driving robot. So
It's like Prometheus, that movie.
are we ready yet? So is this the barrier that AI is generated from human, but we cannot back to be the so the big barrier is the cost. That is my answer. Thank you.
Oh, wow. Thank you so much. I think we really got a rich discussion on the panel, and I truly thank you, and because I've learned a lot also. I hope that the listeners and the guests here also learned something from the panel. I think we have a little teeny bit of time if there's any question from the floor. I will take one if there's any. Oh, yay, we see a hand. Can you, yeah, the mic is coming to you.
Hi, thank you so much for the insightful panel. I believe that as I was listening to your discussion, I was wondering about what is, from your experience in Thailand, in US, and in Singapore, on both things. So first is the consumer or patient behavior. The second thing is the regulatory point of view towards the products that are for preventative care. For example, as right now, I believe that the AI, especially in diagnostics area, it kind of educates and access the market to become more aware of the health risks or potential health problems. But I believe that there is also a gap there, for example, in the products that might perform in the area that post-diagnostic but pre-treatment. So I believe, I was just wondering whether you have any experience in consumer and regulation gap and how to deal with it? Thank you.
I can answer quickly. On the consumer side, I've been very passionate about trying to be able to enable consumers to help with their own prevention, and some colleagues who continue a project we started many years ago, using your mobile phone to encourage more physical activity, because it helps prevent so many diseases. But the latest is they're going to implement sort of a generative AI sort of learning system so that it can interact with the participant to really learn what are the motivational signals most important for that individual. So this idea of a sort of learning, personalized prevention, intervention, I think we'll see more of that. So right, you can personalize therapies based on your genome, but for many things it's about behavior. So trying to understand what are personal motivators, because that's critical for prevention.
For us in Singapore, we actually have issued some guidelines in terms of what constitutes AI as a medical device, as well as some of the principles of AI that you probably need to adhere to if you think you have a product you want to launch. But one of the things that you might want to think hard about as you look at any product or any service you think you want to offer is what is the nature of that service and product you claim to offer, right? If you actually claim to be offering some sort of medical advice, then I think most of the jurisdictions today would then say, but who is the responsible party if anything were to go wrong, right? If you have an underlying doctor who then takes that responsibility and that underlying doctor is jurisdictionally based in that country, then you probably have some sort of pathway forward. If not, I think you might always find it a little bit difficult. Okay, I'll just be very honest about it, because in the end, there will be some of these medical responsibility issues that need to be addressed. Then, of course, after that, if within that you are able to find the right way of doing it, one possibility, of course, is that you find doctors in the hospital who somehow are willing to use it as part of their workflow, right? If it's part of their workflow, then some amount of, again, you'd ask yourself as a company, how much responsibility are you willing to take? Do you have a medical director that oversees your work who actually is in a position to take that responsibility? In order for you to find a pathway that allows the system itself to trust that whatever you provide is a medical product that, that can stand its ground when it's actually scrutinized. But of course, once you're in the consumer space, and the consumer space, if you are just giving someone advice, someone to, things that to do as a lifestyle, we actually much more, how should I say, we have chosen not to wade into that space as much, because we know that if we do, we'll end up actually in a way killing innovation. But what you then have to think about is, what is your pathway? It's after you receive that lifestyle advice, what is the pathway to a medical intervention at the right time? And how will you do that handshake? Because otherwise, you are just a consumer product like any other consumer product. You're not necessarily going to be improving the healthcare of these individuals as well. So maybe those are the two pieces of advice I'll try to give you to actually, as you think through these issues. But you must always stand on the side of the regulator to understand what they're concerned about, so that you can actually help them to solve their problem and make them much more friendly to you in the process.
Thank you so much. I think the key word is collaboration and really understand the key issues. And once it becomes a clinical standard, then you can get reimbursement. Yeah, coming back to yeah. Once it's a clinical standard. So also looking at Dr. Yongyut as well. So thank you so much for listening and participation. I think we all learned a little bit, and then let's go and innovate some more. Thank you.
Thank you very much to all our distinguished panelists, Professor Dr. Yongyut Siriwattana Akson, Professor Dr. Michelle McConnell, Dr. Chong Wei-yang, Dr. Kittapat Bunfeung, and our moderator, Ms. Nadia Sutti Kunpanit, for sharing such inspiring insights and thoughtful perspectives. We truly appreciate your time and contribution today.
And that concludes our morning panel session. Let's give our panelists another big round of applause.
We're going to stay more for the video.
For now, please proceed and enjoy the networking lunch served on the 11th floor. Our staff will be there to guide you to the dining area, and please don't forget to collect your lunch coupon at the front of the dining room. Enjoy your wonderful opportunity to connect, exchange ideas, and continue today's great conversations in a more relaxed setting. Thank you once again to our panelists and everyone here. Please enjoy your lunch.
We'll be back soon at 1:20 p.m.